visited Sweden a couple of years ago and addressed an academic group in relation to some of the ideas we've been developing at NICE about outcome studies. And what I'm going to talk about this morning takes us on a little further from where we were a couple of years ago. So, the problem that I'm going to talk about this morning is that in many areas of policy, particularly the one I work in, which is public health, there aren't very many good outcome studies which answer the simple question that Sandra referred to: what works? We're left floundering around trying to find out what works, looking at evidence which answers a number of different questions, but not that one necessarily. There are still fewer studies which tackle the question which has been enunciated by Ray Paulson, a colleague of ours from Great Britain, who's formulated as follows: what we want to know is what works, for whom it works, and under what circumstances. The number of good studies that give me that answer is very few indeed. The evidence, such as it is often far too imprecise to allow us to determine what the nature of the relationship is between a particular intervention and a particular outcome. Now, the field I work in, public health, those interventions range across a number of things, but they relate to such things as helping people to stop smoking, to change their diets, to take more physical activity, to have their children immunised, to have themselves tested for HIV or hepatitis, and so on and so forth. The traditional fare of public health and disease prevention. And even in that area, where we have a tradition of research stretching back more than 140 years, the numbers of studies that we can turn to as we formulate our guidance at NICE tends to be very few. Now, the argument I'm going to make this morning is not, oh dear, we're not doing the right research. We should be doing more research. We should have greater funding for research. We should get universities to do things differently. We've been saying that for at least 30, 40 years, perhaps longer. Instead, I'm going to argue that we've formulated the problem the wrong way round. And there are two dimensions to that. First, I'm going to argue that it's an epistemological problem. That's a lovely word, epistemological. It's a philosophical word, and it simply means about the theory of knowledge. So what I'm saying is there's a problem here about the theory of knowledge, the way we think things work, especially with reference to our ideas about cause. What causes what to happen? And I'm going to argue that certain ideas that have been borrowed from physics and from medicine have helped to take us up the wrong path in the policy sciences. I'm also going to argue that it's a methodological problem, which is about the poor translation of the principles of evidence-based medicine into other arenas. So, two parts of my argument. Now, the job I do, when I'm not visiting lovely places like here, is I work for the National Institute for Health and Clinical Excellence, which has offices in London and in Manchester, those two photographs. And since 2005, I've led the team there that has developed the public health recommendations for the English Health Service. So the observations that I'm going to make this morning are based on that experience, the experience of leading public health guidance at NICE since 2005. Now, for those of you who aren't familiar with what NICE does, there are a number of very simple principles that we use in all our work. So that's the public health work that I do, but also the work that my clinical colleagues do in evaluating new drugs, the work my other clinical colleagues do in developing pathways for the treatment of particular conditions, and from this year we'll be doing guidance and recommendations and standards for social care. So the principles are to base all the recommendations we make on the best available evidence. That doesn't mean we only look at randomised controlled trials, by the way. It means we look at the best available evidence, which, if we're lucky, will include randomised controlled trials. But in my area, they're pretty few and far between. We always attempt to work out whether something is good value for money. That is to say, the question we are asked by the public exchequer in Britain is what you're recommending, is what NICE is recommending, good value for money? If it's not, even if it works, we won't recommend it. We endeavour to be as open and transparent as we can. Our meetings are held in public, for example, so you can come and watch the deliberations of our committees, and everything we do is published on the website. We try to be clear about our scientific values and the other values that come into play. Because actually, of course, scientific evidence seldom gives you an answer, and it always requires interpretation. We allow contestability, we're challenged at each stage in the process, sometimes as far as the courts of law, and we endeavour to be independent and to be seen to be independent of government and the pharmaceutical industry, but in my case in public health, of other vested interests, which include the tobacco industry, the alcohol industry, the advertising industry, the food retailing industry, all of whom take a great interest in what we do. Now, public health built on the process that was derived from the platform of evidence-based medicine. And this, in turn, has a number of simple principles with which I'm sure you're familiar. To use evidence which is least likely to be biased as the basis for clinical decision-making, or in my case, public health decision-making. The core question, what's the comparative cost-effectiveness of doing X as against Y, or as against doing nothing at all? In order to find the answer, we engage in extensive literature searching across the peer-reviewed scientific literature. We then appraise the literature we find and apply the principles of the hierarchy of evidence, more of which in a moment. We will examine the evidence from randomised controlled trials where it exists, but it doesn't always. And in principle at least, according to the precepts of evidence-based medicine, that should get you the answer to the original question. What's the comparative cost-effectiveness? So in a public health arena, what's the comparative cost-effectiveness of this type of intervention for smoking cessation as against that type of intervention? What's the cost-effectiveness of this sort of intervention to improve the rates of immunisation of children under the age of 5 as against that? And so on. If you're interested in looking in detail at the methods we use, we've just recently brought out the 3rd edition of our methods manual, published in October last year. And in it, you'll find we spent a bit of time looking at the hierarchy of evidence. Now, I'm sure you've seen the hierarchy or various manifestations of it. This version comes from the manual. Right at the top there, 1++ studies, good quality studies, high quality meta-analyses, systematic reviews of randomised controlled trials, including cluster randomised controlled trials, with very low risk of bias. And so on, you go down the hierarchy, and the principle is that at each step down, the chances of bias increase, or conversely, at each step up, the chances of reducing the risk of bias are eliminated. Now, if you're evaluating the effect of a pharmaceutical agent, that's a very, very good way to proceed. If you want to know what the effect of drug A as against drug B, this is a very useful device for evaluating studies, or types of studies. But when you seek to apply it in a broader arena, policy studies or public health, that kind of thing, one has to engage, I think, in a more subtle understanding of what's in there. Now, the core idea behind the hierarchy of evidence is this: how confident can we be that the relationship between the dependent variable, the outcome, and the independent variable, the intervention, is free from bias? It's what Campbell and Stanley, the famous educational methodologists, described a couple of generations ago as the internal validity question. So how good is that relationship between these two things? And obviously, in the work we do at NICE, understanding that's terribly, terribly important. But of course, that is in turn premised on a more subtle epistemological question, because it's based on the idea that the relationship that we can free up from bias is actually a real one. It really exists. And actually it doesn't. It exists as an ideal, as a theoretical construct. But in the world of real-world biology, and certainly in the real world of public health behaviour or policy behaviour, the notion of two variables, untouched by anything else, is only ever an ideal possibility. It's never an empirical reality. Because variables exist within a complex web of relationships empirically, and the notion of one variable acting on another is premised on a particular view of cause, which is derived from physics and not from the behavioural sciences. Now, what's quite interesting is we knew this at least 65 or 70 years ago. American educational and sociological researchers and methodologists, people like Kurlinger, Paul Lazarsfeld, Herbert Blumer, and others, provided a rich understanding of the problem of trying to use the word variable and apply it to human behaviour. They didn't say you couldn't, but they said you needed a more subtle understanding of what you were dealing with. You couldn't treat it as some sort of quantitative thing like an atom or a molecule. Lazarsfeld also drew our attention to intervening variables. The complexities of human relationships are such that the notion that there's just a single relationship between these two things is never likely to happen in real life. And of course they drew our attention to the significance of implementation, that part of the knowledge arena that Sandra was referring to in her talk, process, culture and people. It's quite interesting that much of that knowledge and learning has stuck there in 1950s and 60s American educational psychology and sociology, and has never migrated into the world of evidence-based medicine, nor, I fear, into the world of evidence-based policy either, very much. What I want to do now, though, is focus on the idea of cause that's embedded in all of that, and see where that takes us. Now, the simple idea of cause, the common sense idea of cause, if we represent it diagrammatically, looks something like this. You've got two things, X, an intervention, Y, an outcome, or X, some sort of event, and Y, some consequence of that event. X causes Y. And the causal pathway follows a nice straight line. And that's a really easy thing to understand because, you know, if I drop my pen, falls to the floor, I can imagine the cause of that being the fact that I let it go. There might be some underlying theory, gravitational force, explaining why it fell to the ground rather than flew up in the air. And that's really quite a neat idea. And it's encapsulated Western thinking since the time, really since the time of Galileo, but especially since the time of Isaac Newton, when it became possible on the basis of astronomical observations to predict the positioning of planets on the basis of observation. The idea that there were causal processes explaining the planetary movements which allow for prediction, and that's another ever so important word, prediction, allow for prediction, has dominated our thinking about what science should be. So this lovely causal model provides us with an understanding that is intuitively part of what we teach our children. When the child says, "Mummy, why has that happened?" we offer an explanation, very often in causal terms. And this has been a very successful model. In Newtonian physics, it gives us all sorts of advances. It's the basis of engineering, it's the basis of all sorts of things which help us construct the modern world. A still more astonishing discovery and use of this idea during the 19th century was germ theory. At the beginning of the 19th century, physicians and scientists had no clear account of the origins of common diseases. Death in childbirth was commonplace from what was called puerperal fever. And it wasn't known that it was an infection. All sorts of things were thought to be going on, but the notion that it was an infection was not understood. The major public health scourges, cholera, typhoid, the waterborne diseases, or what we know now to be waterborne microbes, were not known. Through the course of the 19th century, often with bitter rivalry between people we see now as running a common cause, Koch in Germany and Pasteur in France, were barely on speaking terms. Published papers criticising each other's work, but out of their combined work, there gradually emerges, by the end of the 19th century, this astonishing notion that there are these microbes in the environment which cause infections, and if we can eliminate the germs, we can eliminate the bacteria, we can put something in its way, we can protect ourselves from the disease. Still later, following in the pathway of Lister, we get the notion of antisepsis, antiseptic, and then of course antibiotic. The miracle of 20th century medicine. And it's all premised on a nice, simple model of cause. And that simple model of cause seduces us into the notion that we can predict things. If we can prevent this, if we can give this antibiotic, if we can stop this happening, we can predict some element into the future. Just like that neat diagram. But those of you who know anything about physics know that the 20th century saw us move well beyond Newtonian precepts. And indeed, Newtonian physics is but a special case of a much broader physical universe. And of course, modern medicine doesn't operate with simple biological unilinear models of cause. It operates instead with models of pathogenesis, which are multifactorial, in complex webs of causation. And a realization too that biological variation in the human being, as well as a range of other factors, means that you cannot predict with any degree of exactness, at least in the way that that diagram indicates, human pathology. What you need is clinical judgment. So where does that leave us thinking about cause? Well, it pushes us here. Because the trouble is, public health, and I would argue the policy sciences, haven't really caught up. Because in public health, we tend to think of risk factors as the new germs. Agents like smoking, drinking too much, not exercising, eating the wrong food, doing risky things sexually, are conceptualised, to all intents and purposes, as if they were germs or microbes, which if only we could stop, arrest, quarantine, or in some other way prevent, we'd have the kind of new antibiotic of public health. But of course that's a hopeless aspiration, because it's about human behaviour. And human behaviour doesn't actually perform like drugs. So public health interventions, the things we do to prevent these diseases, the sorts of things I spend my life looking for, don't exist as some neat form of antibiotic, public health antibiotic, or some kind of prophylaxis. And why is that? Well, it's very obvious, because it's all about human behaviour, which is far less easy to predict in anything other than a very short-term time frame than what molecules do. So what have we done? Well, what we've done is develop more complex models. That's always the answer. When you reach Thomas Kuhn's anomaly, those of you familiar with Thomas Kuhn, who talked about scientific revolutions, he says, well, you hit an anomaly. I'm saying to you, we've hit an anomaly. But rather than acknowledge the anomaly, what we've said, well, we'll develop more complex models to try and embrace all these anomalies, the things that don't work. And so we come up with more complex models of the relationship between X and Y. One I'm very fond of using myself is an intervention, Dr. X explaining to patient that if they took more exercise, they would reduce their cardiovascular risk. Scientifically, that's true, but if the patient is to get the benefits, a number of things have to happen. So let's develop a complex model. At A, we assume the patient understands what the doctor's saying. Mr. Kelly, if you took more exercise, your chances of having a heart attack would decrease. Well, that's got to be based on the notion that Mr. Kelly, the person hearing it, believes it. Lots of people don't believe it. Exercise makes you tired, sweaty, it hurts you, it's painful. How could that possibly be good for you? Well, let's assume you do think it's good for you. You decide you're going to go and do some jogging. To do some jogging, what do you need? You need some trainers and a new tracksuit. So you go along to the shop and buy some Nike trainers and a Reebok t-shirt and a nice Lycra tracksuit. Does that make you run? Does that reduce your cardiovascular risk? Well, not unless you run. And if you do run, you have to do it for long enough to get the cardiovascular benefit. And that has to feed on actually to a population level, because levels of exercise benefits are population level benefits rather than necessary individual benefits. Something that public health often skirts around as a bit of a tricky anomaly. And so the model then looks like this. All sorts of complex places. And indeed, if it's C, you might finish up at point I on that model, which is a wardrobe full of Lycra training shoes, or Lycra tops, tracksuits and trainers, but no visible cardiovascular risk. So you're still stuck with the same problem of prediction. And bear in mind, many of the interventions that we look at in the public health and policy sciences are much more complex than that. We, for example, were asked to evaluate changing the school curriculum in relation to sex education so that people would use condoms on sexual debut 3 years later. Can you imagine how complicated that diagram is? An anomalous model, in theory it could look like that, but in practice, of course, it's much more tricky. And indeed, we've developed, as I say, these complex causal pathways, complex systems to embrace the complex systems within which interventions take place. Ray Paulson, my colleague from Leeds University, has developed complicated program theories to help us understand it all better, which is actually a great step forward. And we ourselves at NICE use logic models, which look like this sort of thing, explaining all these complex relationships. But it's still, I would argue, heading in the wrong direction. Because the epistemological problem is twofold. One I just alluded to is that we're dealing with two levels of explanation, which are as different to each other as physics is to chemistry, or physics is to biology. And it's the difference between what happens at the individual level and what happens at the social level, or the population level. And very often these two things are completely muddled up. So we need to ask the question, is what we're trying to do by increasing physical activity or reducing levels of salt consumption, are we trying to level the level of population risk or individual risk? Now, it gets muddled because the variables used are of two types, individual and relation. Individual variables that crop up, things like blood pressure, height, your performance on a personality test, some measure of morbidity in the human body, your occupation, or your biological sex. So they're individual characteristics, something in the human being, in the human body, which can be measured at an individual level. Social variables, on the other hand, relational variables, are about relations between groups of people. Relations between groups of people. So our measures of social class, gender, about relationships between men and women, social status, tribe and caste, for example, are measures of social differences in populations, but also relationships between people. Why this is so important is that in the world of public health, one of the enduring problems has been health inequalities. The fact we have a social gradient where the poorer you are, the more likely you are to die earlier and to die of multiple morbidities before you die. The difficulty has been trying to find solutions to that problem. The present government in the UK is committed to finding solutions. The previous government was committed to finding solutions. But because they don't think in social terms at all, they tend to come up with the wrong solutions. One of the most disappointing days I can remember scientifically was when the Marmot Commission came, the Commission for the Social Determinants of Health finished its work. There was a huge conference in London at the Queen Elizabeth Conference Centre by Westminster Abbey. Thousands of researchers and academics, politicians from around the world, and in terms of political support, it was graced by a Prime Minister, several presidents, and from the UK, at least 4 Secretaries of State. And they all, one after the other, bemoaned how awful it was that we have health inequalities. What a bad thing it is, how dreadful it is. And here's Sir Michael Marmot's report showing us how awful it is across the world. But did they see that in relational terms? In social terms? No. Almost every political speaker, at least, spoke in terms of things we could do to individuals. We could help individuals improve their diet a bit. We could get people to take a bit more exercise. They didn't see it in terms of relationships between social classes or social groups, which is the